So good evening, everybody. Good evening, everyone. Thank you, Dr. Suresh, for handing over the duties to me. So today, as he said, is the seventh episode of Diabetic Crossroads, and the topic is diabetic neuropathy. And we have Dr. Sharath as the speaker, Dr. Harish Kumar and Dr. Nandakumar Shankar as chairpersons. I hand over the proceedings to Dr. Prashant Shankar, who will be coordinating everything. Over to you, Dr. Prashant.
Thank you, one and all, and welcome everyone to this seventh episode of Diabetic Crossroads. Just been successfully running for the past few months. We have discussed various basic aspects of diabetes, and now we are into the microvascular complications, where we have discussed both the retinopathy and nephropathy, and we are now discussing diabetic neuropathy. And for that, we have an excellent speaker, Dr. Sharath Menon, and two very senior experienced physicians, Dr. Harish Kumar and Dr. Nandakumar. And I welcome all the attendees into this meeting. And without much delay, I would first introduce the chairpersons and then hand over the session to the chairpersons to introduce the topic and the speaker. So I would first like to introduce Dr. Nandakumar, who is a senior physician who is currently the managing director and consultant physician and diabetologist at Udayagiri Multi-Speciality Hospital, Changanasheri. He had his MBBS and MD internal medicine from MCH Rewa in Madhya Pradesh. He also has got his postgraduate diploma in diabetology. He is also the founder member of Udayagiri Multi-Speciality Hospital and has independent charge of the internal medicine department. He has carried out various research activities and pilot studies. He has been an active member of National API, RSSDI, and international associations like ADA. He has presented free papers and participated in various diabetes research activities. He has been an active secretary of IMA Changanasheri, who has organized various academic meetings during his tenure. And he has also authored books and conducts public educational activities for patients and public on diabetes awareness. So I would now proceed on to introduce our second speaker, who is Dr. Harish Kumar, who is a senior physician and diabetologist at IHM Hospital, Bharananganam, and also he works as a physician and diabetologist at SN Hospital, Kadapura, Niranam. He is a well-known figure in the national and the state circle. He has been the immediate past secretary of API Kerala chapter, probably the most active secretary of API Kerala chapter. And because of his work, API Kerala chapter has received the second best API among the second best state chapter in the recently concluded Epicon. And he has been the past joint secretary of IMA Kerala State, district committee chairman of IMA. He has held various positions like the past president and secretary of Pala IMA. He has received many awards as being a very good organizer and a very good active member of IMA and API. And he is a renowned diabetes health educator. He conducts various camps and conducts various public health education activities. And he's also an invited faculty for the state and national API, RSSDI, and other diabetes conferences. So with this, I would hand over the session to the chairpersons to introduce the speaker and introduce the topic.
Thank you, Dr. Prashant, and welcome to all. And first, let me thank RSSDI Kerala chapter for giving me this opportunity to chair along with my friend Dr. Harish. And I will be discussing shortly about this topic, and Dr. Harish will introduce the speaker. And this is my first presence in this meeting, and I love and enjoying the meeting with all my friends. And in this episode, we are going to discuss about, as Prashant has already mentioned, that the topic is the diabetic neuropathy, very common problem which we come across as the physicians and diabetologists. And this will be detailed by none other than Dr. R. Sharath Menon, who is clinical director of Sharda hospital, and I think he has worked in the Aster Medicity also. And regarding this topic, we all know that the diabetic neuropathy can occur in 50% of the individual with long-standing type 1 and type 2 diabetes mellitus. And if the person is having risk factors like hypertension, dyslipidemia, especially high triglycerides, or a person is smoker, or with the obesity and high BMI, then it will contribute to the diabetic neuropathy and other complications due to that. And in this type of neuropathy, it is very unique that it involves the loss of myelinated and as well as the unmyelinated nerve fibers. And this type of neuropathy is a little bit confusing, because this other neuropathies also has the same type of symptoms and signs. So we must do it proper investigation, and after excluding all those causes due to the other neuropathies, we should diagnose this person as the diabetic neuropathy. There is a picture of mix-up in that. So that is why we have to find out whether there is any other neuropathy during the course of our treatment. And this is, as you know, that there are all three types are there. DSPN, that is the diabetic symmetric polyneuropathy, or sometimes the second is the autonomic neuropathy, and mononeuropathies, and when the roots are involved, that is the radiculopathy or polyradiculopathy. Like that it goes on. And in this diabetic symmetric polyneuropathy, as you know, that there is person will come with tingling, numbness, pain in the extremities, gradually progressing to the proximal part. And sometimes the pain will be there, but during the course of this diabetic progress, these people will say that there is no pain now, but there is a loss of sensation. And that is why the screening is very, very important during the treatment of this with the these filaments, etc. And you should always screen to find out whether there is any DSPN or LOPS, what you call it. That is the loss of protective sensation. That sensation, when gradually lost, then there is a big chances of diabetic foot ulcer, etc. And the other two types, that is the autonomic neuropathy, we all know that it is also involves two systems. That is the parasympathetic, which is the cholinergic nerve fiber, and the other one is the sympathetic, that is the adrenergic nerve fibers. Multiple these organs are involved in, like cardiovascular, gastrointestinal, genitourinary, pseudomotor, metabolic symptoms. All these can happen. And in addition to that, the very much common things like hypoglycemic awareness, they are all due to this autonomic neuropathies. And there may be resting tachycardia may be there, or sometimes there is a prolonged QT interval also there. And in diabetics, we are very common with this dryness of the skin, that is the anhidrosis of the lower extremities, and hyperhidrosis of the upper extremities, etc. And these things are there due to this autonomic neuropathies. And the last one, that is the mononeuropathies, are also very painful type, and it involves the different roots. Then we call it as radiculopathy, polyradiculopathy, like that. So it is a big chapter, and we are sure of getting a detailed account of these things by Dr. Sharath. And now I would like to hand over mic to Dr. Harish to introduce the speaker, and we will listen to the in details. Thank you.
Hello, good evening, everybody. I first of all thank the RSSDI Kerala chapter, especially Dr. Chandani, Dr. Suresh Kumar, and the Nambiar, and the coordinator, Dr. Prasant Sangar, for inviting me to chair this session along with my close friend Nandakumar. So straight away go to our speaker, Dr. Sharath Menon R. Is a consultant neurologist and neuromuscular autonomic specialist in charge of the Neuromuscular and Autonomic Clinic, Global Center for Excellence in Neurosciences, Aston City, Kochi, and the clinical director, Sharada Hospital, Kochi. He has done his MBBS, MD, MD, DPNB, DM, DPNB Neuro, MNMS, is MRCP London, UK, MRCPE, MRCP Neuro, UK, and a fellow of the European Board of Neurology. And he's a fellow of Autonomics and Peripheral Nerve, Amsterdam. Special training in the University Hospital and Zurich and King's College Hospital, London. Publications 16, and area of special interest is autonomic neuropathy, peripheral nerve and neuromuscular, and achievements and awards. Core member of International Auto Reach Committee, Peripheral Society USA, Medical Advisory Board member, Indian Subcontinent, International USA, member of the American Autonomic Society USA, traveling fellowship recipient of IAN 2018, WN 2019, and outstanding Outstanding Achievement Award in Neurosciences Kerala and Neurologist 2022. Is a Joint Secretary elect Kerala Associate Neurologist. With these words, I introduce Dr. Seth Menon R to give his lecture on peripheral neuropathy. And I'm sure you all agree he'll be a great speaker, and we'll listen to him.
Dr. Sharath, you are muted. You are muted. Please unmute yourself.
Yeah, am I audible?
Yes,
Audible,
yes.
audible.
Yeah. Thank you, sir, for that warm introduction. And I think I'll share my presentation. Right? I think who can you make me a host so that I can share?
You have made a co-host actually. Already I made you co-host. 1 minute. Once more I will make it in case it's not there.
Yeah,
You are
I'm not
already a
able to do
co-host.
that. 1 minute, 1 minute. We are not able to share now.
Why? Prashant, ഒന്ന് നോക്കിയേ co-host അല്ലേ?
Co-host ആയിട്ടാ കിടക്കുന്നത്. സാറിന് ഒന്നും കൂടി ഒന്ന് മാറ്റി നോക്കി.
ഇപ്പൊ വന്നിട്ടുണ്ടായിരുന്നല്ലോ ശരത്ത്.
ഡെസ്ക്ടോപ്പിൽ വരുന്നില്ല ആക്ച്വലി. 1 minute.
Co-host ആണ്. ഷെയർ സ്ക്രീൻ കാണുന്നില്ലേ? അടിയിൽ ഷെയർ സ്ക്രീൻ ആ ഗ്രീൻ
ഷെയർ സ്ക്രീൻ കാണുന്നുണ്ട്. പക്ഷെ ഞാൻ അമർത്തുമ്പോൾ ഇറ്റ് ഈസ് കമ്മിങ് ലൈക്ക് ഗൂഗിൾ ഡ്രൈവ് അങ്ങനെയൊക്കെയാണ് വരുന്നത്.
ഗൂഗിൾ ഡ്രൈവ്
മിനിമൈസ് പ്രസന്റേഷൻ മിനിമൈസ് ചെയ്തിട്ടുണ്ടോ ശരത്ത്? ഡോക്ടർ ശരത്ത് പ്രസന്റേഷൻ മിനിമൈസ് ചെയ്ത് വെച്ചിട്ടുണ്ടോ? മിനിമൈസ് ചെയ്തിട്ടുണ്ടോ? മിനിമൈസ് ചെയ്ത് വെച്ചിട്ടുണ്ടെങ്കിൽ നമ്മളതൊരു
1 minute. Yes, is it visible?
No.
Yeah, is it visible now?
Not yet.
No.
You have to share it. Try sharing it.
1 minute.
Let's go to share screen and then go to the.
അല്ലെ പ്രശാന്തിന് അയച്ചു കൊടുത്താൽ അല്ലേ?
Prashant, I think I have that. I think.
Yeah.
Can you able to share that?
Yeah, just a minute.
ശരത്ത് അത് ഡബിൾ ക്ലിക്ക് ചെയ്ത് നോക്കിക്കേ, ചിലപ്പം കാണുമായിരിക്കും.
1 minute.
Yeah. Sharad, is it okay now?
Yeah. So I think I'm not able to change. Change it.
You can say next. I will change. Yeah.
Okay. So first of all, I should thank the office bearers of the RSDI, especially Dr. Prashant. He's a old friend of mine for a long time. So it's a great pleasure to give a talk, especially on diabetic neuropathy in this platform, because RSDI is known to me when I started my MBBS as an MBBS student, and being there in many of the conferences from the undergraduate level. So it's a great honor to be here and present this topic. And this topic, I would say that it's close to me because I'm working in this field for a quite long time. So neuropathy is my primarily specialty. And in our neuropathy clinic, we used to see, I mean, most of the time we used to see the diabetic neuropathy. So it's a common disease, especially in our part of the country. And we'll be seeing a lot of different types of neuropathy also. So I'm sure that all the clinicians will be dealing with diabetic neuropathy, and we are maybe as a neurologist, I'll be dealing with very small subset of diabetic neuropathy. So this is a very common entity, which is well known for the even for an MBBS students. Diabetic neuropathy is a well-known entity. So to start with, next. To start with, I just got this WhatsApp image recently regarding the statistics of diabetic population and pre-diabetic population in men in India. And we can see that how our state doing. So we know that Kerala is notoriously famous for diabetes capital. And we can see the majority of the diabetic population is in the south. So coming to diabetic neuropathy, so as Nandu Master already told, we would see that around 50 to 60% of diabetics have diabetic neuropathy, and this is a objective assessment. When you take the subjective assessment, it might go up. So, on average, 50 to 60% of diabetics can have diabetic neuropathy, and most of the time, diagnoses are done lately, and unfortunately, at the time, most of the damage had already occurred. So the damage to nerves is a irreversible thing. So that most of the time when the patient comes to the clinic and we do the nerve condition study, which is the gold standard one, and we can see that the neuropathy has already occurred and the damage has already occurred. So the most important thing is to screen it as early as possible, especially in case of diabetic type 2 diabetes. Next. So this has already been discussed. There are 3 types of nerves which can be affected. It can be sensory, it can be motor, it can be autonomic, it can be a combination of all the 3, or it can have sensory motor involvement. It can purely present with dysautonomia or autonomic neuropathy. And regarding the different types of nerves, it can become myelinated, unmyelinated, large fiber, small fiber. So diabetes can present with any n number of nerve involvement, any type of presentation. So we will be in a routine clinic, we'll be saying different presentation of diabetic neuropathy. So this is not if you say that as a commonly we would see diabetic sensory symmetrical polyneuropathy as the most common thing, but still we can have patients presenting with atypical presentations. So as a clinician, I would say that we should always look, I mean, apart from the common presentation of diabetic neuropathy, you can have some atypical ones also. Next. So this is the common schematic presentation of symptoms which we get in a diabetic neuropathy. Can start with negative. We can have negative symptoms or they can have positive symptoms. Negative symptoms, most commonly, they can have numbness, and positive symptom, they can have stabbing pain, neuropathic pain like burning sensation, hyperalgesia, allodynia, and coordination difficulty like gait ataxia, falls, muscle weakness, and bladder power involvement. Next. So something which I love to teach is diabetic autonomic neuropathy, because I'm more specialized in the autonomic neuropathy. So which is a very small subset of neuropathy which is being diagnosed. But when you take as a whole, most of the diabetic neuropathy patients will be having minimal autonomic involvement. So it is very difficult for them to have a subjective or a symptomatic presentation at that time. But objectively or bioelectrophysiologically, we can find out they might be having this dysautonomia from the start of neuropathy. So diabetic autonomic neuropathy doesn't mean that the patient should have a long-standing diabetic neuropathy or they should have a high glucose level or like that. Autonomic neuropathy can coexist with the routine or the normal sensory motor neuropathy, and sometimes they can solely present. So they can have different presentations, like Dr. Nandu was told, that it can affect all the system. It can be system specific, like cardiac dysautonomia with resting tachycardia, and they can have orthostatic hypotension, intolerance, syncope, and they can have painless MI, then pseudomotor dysfunctions like anhidrosis, focal, diffuse, hyperhidrosis, gustatory problems, and bladder and bowel involvement. Like they can have this diabetic diarrhea, constipation, nocturnal frequency and urgency of, and also sexual dysfunction and retrograde junction. So a lot of dysautonomic symptoms they usually present with. And GI symptom is also very common. They can have postprandial bloating. They present with recurrent vomiting, so, and abdominal pain. So dysautonomia, or what do you call it, DAN, diabetic autonomic neuropathy, is as common as when compared to the normal variety like sensory motor neuropathy. DAN is very common, especially in type 2 diabetes. They can even present with DAN. Okay, next. So this is the pathophysiology. We know that the pathophysiology of diabetic neuropathy is a debated subject, but still on overall, when you have an hyperglycemia or a glucose load in the blood, so they can have damage with the production of reactive oxygen species. They can have mitochondrial dysfunction, and basically they can affect the Schwann cell of the nerves and have both microvascular damage, and also they can have neuronal damage. So this is a schematic representation of what happens when there is a hyperglycemic overload, and what happens when the patient have a diabetic neuropathy. So they can have both microvascular damage, like in ischemia. They can involve the smaller vessels as a nervosum, and also they can have the indirect neuronal damage also, like can have demyelination, axonal loss. So these are usually we pick up with the help of electrophysiology. We have the electrophysiology equipments to pick up the neuronal damage, but mostly the microvascular and all these things are not being picked up. It's difficult to pick up. So what we see in electrophysiology is the neuronal damage. Okay, next. So coming to the types of diabetic neuropathy, so broadly it can be focal. So we can have focal neuropathies like entrapment neuropathies, mononeuropathies like carpal tunnel, tarsal tunnel, cubital tunnel, meralgia. So, and they can present with cranial nerve involvement. So they can affect all the cranial nerves, mostly in the ocular, the 3-4-6 complex. And they can sometimes present with the focal neuropathies of the abdomen. It's known as truncal radiculopathy or truncal neuropathy. So usually they can present with these patients, which we see is that they can present like a focal swelling of abdomen, and sometimes they can have an umbilical hernia. So that is basically these neuropathy can affect the thoracic nerves and produce a focal bulge. So that is a truncal radiculopathy. Then coming to the most common, like diffuse neuropathies, that is the length dependent neuropathy. The diabetic sensory motor, the most commonly is the sensory one, which can be symmetrical, and they can have motor involvement. They can have symmetrical sensory motor diabetic neuropathy, the length dependent one, which starts from the feet, slowly progressing to the proximally and can affect the hands, upper limb also. Then the other type of neuropathy is the small fiber neuropathy. So they can have only painful neuropathy, which affect the small fibers, the typical unmyelinated fibers, the C fibers. They can have with allodynia, hyperalgesia, and present with autonomic neuropathy. Then they can present purely with the purely with the pan dysautonomia, affecting the autonomic nervous system, irrespective of parasympathetic and sympathetic. So they can have pure pan dysautonomic presentation. And others are the diabetic cachexia, that is a treatment-induced neuropathy, and we'll come to that in the next slides. So DSP, that the distal symmetrical sensory polyneuropathy, is the most common form of diabetic neuropathy, and it's observed. I would say that more than 50% to 50 to 70% we will be seeing the most common presentation will be a DSP. Yeah, next. So these are the types which I already told regarding they can have the large fiber involvement and only present with the sensory problem. They can have the main issue will be gait, the gait abnormalities, gait ataxia, difficulty to stand with eyes closed, and they can have all sensory involvement. So the second one is the small fiber. They only present with a subset of symptoms like hyperalgesia, thermal. They can have thermal problem, like they cannot appreciate the temperature, allodynia. On examination, the other things will be normal. The large fiber and the tendon reflex will be normal. They won't be having much motor function. But usually, small fiber neuropathies can have autonomic presentations also. Then the atypical variants like proximal motor neuropathy, they can present with CIDP. So I'll take each one of them. Mononeuropathies, of course, I have discussed. They can present with cranial neuropathy, carpal tunnel, entrapment neuropathy, truncal neuropathy. Next slide. So most common one is the length-dependent neuropathy, which starts from the feet, slowly progressing to the legs, and once it crosses the knee, the arms will get affected. It can even spread to the trunk, and it can have the swimming suit-like presentation. So it's a very slowly starting neuropathy, starts slowly from the feet, which is progressing down. This is the most common type of neuropathy observed by us in the clinical OP. And usually most of the symptoms in the initial phase won't be there. So patient can go with this neuropathy for a quite long time. And as I said, I mean, autonomic symptoms may not be noticed at the beginning. So they might be, so we need to look for that actually. So in any case, in any patient presenting with a diabetic neuropathy, we have to check for autonomic dysfunction. So that is a one take-home message, that a proper panel or a protocol should be conducted in all the cases of neuropathy, diabetic neuropathy. Next. So what are the red flag signs? When you see a diabetic neuropathy, we know that this is the most common type. We all know that when a patient presents symmetrically from down to up. So this is the most common one. It's, we know that it's a very slowly progressing one. But what are the red flags where we need a high index of suspicion that this requires a aggressive treatment or a different treatment? So what is a rapid progression? You know, when you see a patient of diabetic neuropathy in your follow-up having a rapidly progressing neuropathy, it means even the common sensory, symmetrical sensory motor neuropathy is rapidly progressing. It is extending to the trunk, to the arm, to the face, or when the patient start complaining of a motor weakness, especially the proximal weakness. Patient has difficulty to getting up from the bed or the seat, or not able to climb up or down the stairs. So these are one of the main red flag signs. Then other is asymmetry. So we know that the classical DSPN is a symmetrical variant, but when the patient present with an asymmetry, like an asymmetrical motor neuropathy or asymmetrical sensory motor neuropathy, then that is also a red flag sign. Then dysautonomia itself is a red flag sign in the sense that it can carry a lot of morbidity and mortality to the patient. So the patient should be properly evaluated for autonomic neuropathy. Then cranial nerve involvement, it's also a red flag sign, because we need to rule out, because you can't keep that cranial nerve neuropathy due to diabetic cranial neuropathy. We, in a diabetes patient, any cranial nerve involvement should be properly evaluated. Next. So this is the radiculoplexural neuropathy, commonly known as DRPN. the Bern-Garland syndrome, or the old name is diabetic amyotrophy. So these are the atypical ones which would require further management, further treatment from a neurological side, like they need to be properly evaluated and they should start on immunotherapies. So diabetic amyotrophy is one such condition, and we need to keep in mind that it's not that uncommon. So diabetic amyotrophy is a commonly encountered diabetic neuropathy, and it's properly treatable. So that's one thing, that it's had a good recovery with treatment, but the need for high suspicion is required in a patient presenting with an asymmetrical, painful neuropathy of one leg, especially involving the proximal leg, and it affects the thighs and can affect the calves. So there will be, the patient starts with a severe painful neuropathy asymmetrically on one side, then they can have the opposite side involvement also. And on examination, you can see the muscle atrophy also. So, and most commonly, it affects the lumbosacral plexus, but quite often it can affect the cervical plexus also, the brachial plexus also. So they can have a presentation similar to Parsonage Turner or the brachial plexitis. They can have an asymmetrical brachial muscles involvement with muscle atrophy. And usually it is picked up with the electrophysiology, nerve conduction study. A good nerve conduction study can pick up the asymmetry, the pathology which is happening. And MRI also can definitely delineate the root enhancement, especially affecting the root and plexus. And these patients do well with IVIG, and they do very well with IVIG, and the recovery is good. And with physiotherapy, and usually they don't require a long-term immunomodulatory therapy also. So it's a disease which can be treated if it is properly picked up early. Next. Now this is the another variant which quite often we get confused, because it's a very symmetrical presentation of diabetic neuropathy. It is CIDP. Everybody will be knowing about the AIDP, Guillain-Barré, and the chronic immune-mediated demyelinating polyneuropathy. So diabetic patients are prone for diabetic CIDPs. They can have other CIDP also if they have other disease. They may be harboring some other comorbidities also. But diabetes per se can also present with CIDP. They can have symmetrical proximal weakness. They present with start with proximal weakness, and it may be progressing rapidly with sluggish absent DTR. They can have both sensory motor involvement. Usually these can be differentiated on a nerve conduction study. CSF should be done, and the cutoff, usually we take the protein more than 100. In diabetic patient, the protein levels are usually high. So the albuminocytological dissociation is quite tricky in CIDP due to diabetes. MRI can pick up certain findings like root enlargement and all. They are they're responsive to steroids. So this is one thing where steroid can be tried in diabetes. If you have a good endocrinology, diabetology team in your hospital, now if you can hike up the OHA or the insulin dosage, we can still give steroids. And these are steroid responsive neuropathies. And if that is not possible, even IVIG can be tried. And these patients should be on immunomodulatory therapy. So once the steroid is, the induction phase is over, then you can, as early we can switch over to the secondary immunomodulators. Okay, next. So this is mononeuritis multiplex or vasculitic neuropathy. This is another asymmetrical neuropathy which can have a non-contiguous nerve group or a nerve. It can start with the upper limb involvement, single upper limb involvement, like involving the median nerve or the radial nerve. And in a due course, they can affect the totally different limb, the opposite right limb, so or left limb, lower limb. So they can have asymmetrical presentation. They won't be. They usually can be painful also initially, and they can have both sensory and motor involved. And we usually see a typical nerve conduction finding that initially they can present like a demyelinating neuropathy with conduction block, and also that is one thing we might miss that diabetic, it could be a demyelinating neuropathy. So, but the thing is that after a few days, maybe after the initial 3 to 5 days, the axonal thing come up, because this happens because of the vasculitic neuropathy. So when there is a block in the vessels, the vasa nervosum, initially there will be demyelination. Then what happens is that after that there is an axonal loss. So this is very important. So initially we can miss this. We can actually think like a demyelinating neuropathy, but actually this is a vasculitic neuropathy. And of course, with NCV, we can have a picture like this. And other thing is nerve biopsy. So there are few areas where that nerve biopsy is required. So in a classical diabetic neuropathy or the length-dependent neuropathy, we don't essentially require a nerve biopsy. But there are conditions where we feel that the diagnosis is not proper, that the patient is having some atypical presentation, like one is vasculitic neuropathy, mononeuritis multiplex, another is CIDP. Even in CIDP, when you have a long-standing neuropathy, sometimes we won't be able to pick up clinically. So nerve biopsy is required in diabetic CIDP. So these are the two main things. And sometimes they can have some harboring comorbidities also, like something they can have a toxic, or maybe they have some other plasma dysplasia. So in such case, some deposits, we can have amyloid. So these are the things where we require nerve biopsy. So nerve biopsy is a helpful tool for a neurologist in case of doubt, in case of clinical doubt. So they usually do well with steroids and immunomodulators. So we usually see such presentation. It's not that uncommon. So we have patients with mononeuritic presentations of diabetic neuropathy on steroids, on long-term immunomodulators, and they do well actually. Next. So when to get tested? This is a very important thing. So we know that the majority of population, diabetic population, are type 2. So whenever you diagnose a patient with type 2 diabetes, we have to start evaluating for neuropathy. So that is a mandatory thing, and it is being proposed by the ADA and also from the ANM, the Neuromuscular Electrodiagnostic Association of USA. So any patient which is the new patient who is being diagnosed as type 2 DM should be evaluated with a proper protocol, which includes the sensory motor and autonomic evaluation. So in general OP, even we can do the 128 hertz frequency tuning fork test, 10-gram monofilament test. These are all important to pick up as a screening method. And the gold standard is always a proper electrophysiology with nerve conduction, which the lab which also have as the equipments for testing autonomic neuropathy also. And in case of type 1 diabetes, we know that type 1 diabetic patients will have a slow progression, especially the neuropathy, it will take time to develop. So with the long-term cohorts of diabetic neuropathy in type 1, we found that usually there is no urgency to test them for neuropathy during the time of diagnosis, but they can be tested after 5 years. And then these, both the type 1 and type 2 diabetes should be screened or tested annually. Next. So this is the nerve conduction test which we do. This is our bread and butter, and what we do in our electrophysiology lab is nerve conduction test, and it's a properly done test actually, and it has to be guided, even though the technicians are doing in most of the labs. And a proper neuromuscular specialists need to guide them, especially to pick up this in atypical cases like vascular neuropathy, CIDP, and all. We need to have a proper electrophysiological evaluation. And next is EMG. So EMG is usually not routinely done for diabetic neuropathy, but in case of radiculoplexor neuropathy or atypical presentation, we usually combine. So when you need to have a nerve conduction plus EMG also. So that will give you the best yield. Next. So this is the thing which is, I would say it's new to even for most of the neurologists here, because this is a new branch, hardly in in the Western country for the last 5 to 6 years. So autonomic testing, currently we have autonomic testing in Kerala. And we, as in Aster, we have developed a state-of-art autonomic lab. So my specialty is more into this small fiber neuropathy and autonomic testing. So because it's the autonomic neuropathy is the most, I would say that it's the most dreaded part of neuropathy, because that carries the morbidity and mortality in any diabetes patient. So you need to have a proper autonomic lab to pick up different autonomic presentation. And I've written a lot of abbreviation, but I would say that HRV is heart rate variability. So we have equipments to test heart rate variability. So what heart rate variability, I would, in a common language, I would say that it's a difference between one beat to another. So heartbeat, beat to beat variability. And usually we should know that heart is not a metronome. That means it is not 1:1 like that. So there is variability. So if a patient or a person has variability, that's a good sign. If there is no variability, and that's not a good, that's an ominous sign. So we have testing basically to pick up heart rate variability due to different provocative measures, like patient in sitting position, in standing, patient taking deep breaths, doing Valsalva's maneuver. So it's a compulsive procedure. It takes time. We usually take a lot of readings and then get the average, and it is matched to the age and sex of the patient. So that is heart rate variability. And another is CART, that is again known as cardiac autonomic reflex testing, which again include the heart rate variability, which check the vagal indices, and which is a sign of a marker of parasympathetic dysfunction. And they can have sympathetic involvement also, where we check the different sympathetic testing. Like one is the sympathetic skin response, where we test the we usually with the electrophysiology, the NCV equipment, we usually put a electrical stimuli, and we usually pick up the sympathetic from the feet and the hand. So that usually that is a value which we get from the equipment, and it's usually matched with the age. And the third one is HUT, which is I think I would say that HUT, and I think I would show you. Can you show the next slides? Yeah, this is the monitor. I mean, recording monitor, where we usually see the different parameters. You can see a lot of green and red lines. This is the BP charting, and this is how we record each and every minute. So it's basically beat to beat, and usually we do it on a usually take a 5-minute. Sometimes we take a 10-minute strip. So we see the dip in the heart rate, blood pressure. So this is the monitor representation of what we see in the autonomic lab. Next. Next. Yeah, this is the head tilt table test, and this is also a very commonly done test in our lab. And I would say maybe post-COVID, other than diabetes, also post-COVID dysautonomia was so rampant, and we were doing it on a regular basis. And dysautonomia was quite common in post-viral COVID syndrome, the long COVID syndrome. So HUT, the term shows that it's head up tilt table test. So basically, the patient is being lie down in a supine position for 5 minutes. We'll take the recordings, and then slowly patient will be lifted to a 70-degree tilt and see what happens with the heart rate, the BP. Then we used to record the clinical symptoms. And normally we do it, that is the normal HUT, the unprovoked HUT. And we can do after a meal also. So those patients with the GI symptoms, GI dysautonomia, they have a positive HUT after taking a meal. So what we do is that when we do a normal HUT, if you get a normal HUT, then we ask them to have food and come back. So then we do it again. So these are the provocative measures. So that is a provocative HUT. Then we can give medicines, like you usually give oral sorbitrate or nitroglycerin, or even isoprenaline has been given. We commonly use for getting a provocative HUT. So this is how we see whether there is any drop in the BP when the patient stand up. And there is the cutoff is 20 millimeters of mercury in systolic BP drop and 10 millimeters of mercury in diastolic BP. So there are set protocols followed before taking any hut, and the readings are also done on a typical protocol based method. So this is a very validated test, and it's commonly done test in our autonomic lab. Next. Now coming to the pseudomotor. So pseudomotor dysautonomia is also requires lot of time-consuming procedures. Like you can see on the right side, that is the qualitative assessment when a patient have a pseudomotor dysfunction. This we usually paint with the povidone starch and see if there is any color change. This is basically a patient with a non-length dependent dysautonomia. So this is not the typical one, but this is the typical one. You can see the color change is not properly. This with patchy involvement. So this is a case of pseudomotor dysautonomia. And on the left side, you can see the different red, yellow, green. These are the tests which is called QSAT. That is the quantitative pseudomotor axon reflex test. This is basically to assess objectively assess the sweat production in the patient with autonomic neuropathy. And down you can see the pictoric representation. So that is also a test we do. It's known as pseudoscan. It's an FDA approved machine equipment which is now available comparatively to equivalent efficient with PSAT and skin biopsy. So this is a screening test where we can get the basic pictorial representation of sweat production in the hand and feet. And basically by the principle of reverse antiphoresis, they pick up the chloride chemical conductance. So these are usually we don't go with a single test actually. We do a battery of tests to see whether these findings are consistent. Next. Now, what are the other tests? So there are, if you feel that the tests are ambiguous, that we are not fitting the clinical side and the tests are not showing properly, then we have confirmatory tests with a skin biopsy. We used to do skin biopsy, and in India we used to send to NIMHANS because they have a very good lab. They have a very good neuropathology lab with dedicated electron microscopy and immunohistopathology. So we take a punch biopsy from the calf, and it should be a deep one, and it's usually we usually send to NIMHANS. And what we exactly look are the intraepidermal nerve fiber length. So that is a gold standard thing for small fiber neuropathy. So we take the they will check the thickness of the epidermis, the nerve fiber length, and also they can assess the sweat gland. So that is also the sweat gland can be assessed whether the numbers are normal. So this is how the pathology. We are talking about the pathology of autonomic neuropathy. Then the last one is microneurography, which is not available in India. They have special needles to check the autonomic nerves, even the unmyelinated fibers like C fibers, A delta fibers. So that is not available right now in India, but it's commonly done in West, especially in UK. Next. So coming to treatment, then I'll brief it now. So the most important part of treatment is that we know that the classical diabetic neuropathy cases are irreversible. So is there any option for halting the progression? So the studies are ongoing. So now we have precision medicine, we have genetic medicines where we can pinpoint we have the genetic exome sequencing, especially in small fiber neuropathy, where maybe in long future we can have gene therapies for that mutations. So that is one option. The trials are ongoing. So as of now, it's basically a symptomatic treatment for the painful neuropathies and strict control of sugars. I think I would go much into that because I know that we will be knowing about the time in range and the need for HbA1c monitoring. Next. Next slide. So this is basically the pharmacological target, like controlling the hyperglycemia. I think these things are well known. Next slide. Yeah, treatment option. These are the few molecules which can be tried actually. So we are using that. So we know that, I mean, I would say it's in the early phase to say that if there is any significant improvement or halting regarding halting of the progression of symptoms. But I would say that ALA, especially the alpha lipoic acid, it's a good drug. You can try. Maybe we can try on a long in a much higher dose. And the other ones, the aldolase, aldonyl, that one molecule is aldonyl or aldristar. These are the brand names for aldolase. So they can be tried. The palmitoyl ethanol, I mean, that's a newer kid in the block. So this can be actually, I would say it can be tried in case of refractory neuropathies. But currently, we don't have evidence-based medicines for this medicine, whether they are halting the progression. But these are basically an add-on right now. Next slide. Now, this is the flowchart for painful neuropathy. So this is what we usually see. You know, the literature of, we have already talked about the different type of neuropathy. So in the ground, in the clinic, what we usually is how to treat any neuropathy. So FDA has basically approved only 2 drugs, that is pregabalin and duloxetine. But the other nice one, the nice guidelines of UK and all, they usually do, they can take the TCAs and SNRIs, the tricyclic antidepressant or the uptake receptors inhibitors. They are also can be started as a first line treatment. So basically, it's right. So don't look at the right side. You just look at the left side level, pregabalin, gabapentin, valproic. These are the drugs which is commonly all the drug armamentarium that we have. But don't look at the recommended dosage. None of our patients will tolerate such dosage. So that is one thing I should tell. I mean, I have 2 suggestions to the clinicians, maybe from the experience of treating few neuropathy patients. Next slide. This is a condition known as erythromelalgia. I think many of the physicians might have gone through this. Erythromelalgia is basically severe painful hands, reddish hands. So they can have diabetic neuropathy patient can present with erythromelalgia. It's one of the presentation of small fiber neuropathy, and they actually do well with anticonvulsants. So when you see a patient with red hands, not compliant on the usual neuropathic medication, you can try with anticonvulsant. They do well with Septol, carbamazepine, lamotrigine. So erythromelalgia is one presentation of neuropathy where they do well with the anticonvulsants. Next. So these are the suggestions actually. Basically, there is no set protocol, even though FDA tells you that these are the primarily first line treatment. The treatment should be tailor-made, should be along with the patient. We need to look into the different comorbidity the patient is having. Especially, there are a lot of drugs patient might be taking. So we can't give some drugs like especially the TCAs and SNRIs when the patient is having a dysautonomia or autonomic symptom. We need to avoid amitriptyline, duloxetine. So it's basically tailor-made. Combination can be tried. So you don't need to be start with a single drug. Even combination can be tried initially itself. And what I would suggest is that to start with a lower dose. Now we need to find which is the lower dose of all the available molecule and to start with that. Because mostly what we see that patient if start with 75 milligram pregabalin or 150 milligram pregabalin, they are not going to sustain and they will come back again and they will complaints of the side effects of the medicine. So I will always say to the patient that it takes time to get a optimal response. The time is important, and the titration time is also important. For example, the pregabalin usually follow a linear pharmacokinetics. In such case, pregabalin you can actually increase in a shorter period of time. But whereas the normal gabapentin and other amitriptyline, the TCA, it usually takes time for you to upgrade or uptitrate it. Okay, next. Now coming to immunotherapy. So this thing, again, I've already told about the need for looking into the atypical presentation of diabetic neuropathy, like a patient presenting with radiculoplexural neuropathy, CIDP, vasculitic neuropathy. They have to offer, these patients should be offered immunotherapy. Next. Now this is the new thing, the precision medicine. Now, currently there are available genomic testing. Now, when you suspect a patient with a refractory small fiber neuropathy that is not responding to any kind of drugs, we can still use the genomic sequencing. And if there are mutations, like usually we see the slow sodium channel mutation, 1.7 mutation, actually they do well with lacosamide. So there are subset of neuropathy where we can do phenotyping, like with the current available electrophysiological studies and genomic medicine, we can actually get the phenotypes of this neuropathy and they can be offered medicine. So basically, maybe in long term, we can have gene therapies also. Next. Dysautonomia is an entirely big topic to deal with. I would say that dysautonomia is one of the most difficult to treat neuropathies. They should be, we should actually, with all the current available electrophysiological studies, we can pinpoint which nerve is affected and which system is affected. Even for GI, we do the scintigraphy. We do the radionucleotide scintigraphy to see the gastric emptying time and all these. So we have a lot of dysautonomic patients. So most of them are symptomatically treated. It should be symptom specific and target specific. Next. So few sentences about TINT. This is a treatment-induced neuropathy in diabetes. So this is actually due to treatment. Now, when you start an insulin or a new oral hypoglycemic agent in a patient with dysautonomia, with a patient with a newly diagnosed sugar, they can present with a severe painful small fiber neuropathy. And they can have early dysautonomia also, and that is known as diabetic cachexia. So this is usually a self-limiting neuropathy. So there is no need to stop insulin or OHA in this patient, and it's a self-limiting one. So we need to be sure about this diagnosis: treatment-induced neuropathy. Next. Special mention. Why I want to say is that neuropathy patient, they might have when patient taking metformin, they can have vitamin B12 deficiency. You need to look into that. Hirata disease, it's not that uncommon. I've seen around 3 to 4 cases in the last few years. That is when a patient on ALA, alpha lipoic acid, can have autoimmune insulin antibody. They can present with significant hypoglycemic episodes. So that is one thing. That's not a Hirata disease. Then this, the third one is very common, I think. I would say that this is very common because the problem is that we are not picking it up. They usually come with non-diabetic neuropathy or the idiopathic neuropathy. We do all the testing, and sometimes they may be harboring a pre-diabetes or some of the values will be abnormal. Like in such case, we have to do GGT, the glucose tolerance, GTT, the glucose tolerance test. So I would suggest, if you feel that the patient is not having any other comorbidities, not having diabetes, but still patient is having neuropathy. So it might be labeled as idiopathic or hereditary neuropathy initially, but sometimes they may be having glucose tolerance or pre-diabetes. So you can do the GTT test and find out whether they are a case of a pre-diabetic neuropathy. And sometimes I've seen cases with diabetic neuropathy being treated as diabetic neuropathy for quite a long time. And we can get the electrophysiological studies suggesting of demyelinating neuropathy. Sometimes they may be having hereditary neuropathy also. So we need to, as Dr. Nandoma sir already told, they can have added neuropathy. So that is also a important take-home message, that diabetic neuropathy can have added neuropathies. They can have metabolic neuropathies or sometimes a hereditary neuropathy. Next. I think these are the no pharmacological support medicines. Next. So treating associated problem, like they usually can have depression. So that is where you need to get the medicines according to the patient. So when a patient having associated depression, even you can try like TCAs, SNRIs, rather than the normal gabapentinoids or pregabalin. Usually they do well. So actually a proper clinical profiling of the patient should be done, whether they have depression, they have anemia, because anemia is one of the reasons for restless leg syndrome. Sometimes this neuropathic patient can have restless leg syndrome. So when you treat neuropathy alone, the patient won't be symptomatically getting better. So in that case, you can add clonazepam, pramipexole if you feel that the patient is having restless leg syndrome. So I would say that it's a mixed bag. Diabetic neuropathy might not come alone. They can come with the associated symptoms. Next. So then few sentence about the diabetic foot. I think it's a well-known topic. Next. So this slide I usually keep in every diabetic neuropathy presentation because diabetic foot care is so important. Any patient with diabetic neuropathy, just like you go and have your brushing of your teeth, just like that, a diabetic patient should be taking care of their feet properly, and they should have a proper diabetic foot care at night. Next. Thank you. Thank you for patient listening.
Thank you, Dr. Sharath. Dr. Harish, comments?
It was a very nice presentation. I think we covered all the aspects of diabetic neuropathy and the newer drugs and the pipeline and the newer thing. I think the topic is open for discussion. Any questions or queries or any opinion from our audience?
There are two questions in the chat box.
Yeah, actually, one question was the talk already. We have discussed that topic. Is it the first talk? First question was, can you repeat what you said about red flag signs of neuropathy?
Yeah, the major red flags is basically one is the rapidity. When a patient having a routine, the normal diabetic neuropathy patient can have rapid progression. So rapid progression is definitely a red flag. Asymmetrical presentation or asymmetrical involvement of limbs is red flag sign. Proximal involvement. So when a patient with a distal neuropathy rapidly have a proximal weakness, the patient present to your OP like having difficulty in getting up. So these are the things which should be taken with a high suspicion that these require further evaluation. Then cranial nerve involvement, autonomic neuropathy. Autonomic neuropathy per se is a entity which should need to be watched.
One more question is there. I think whether we can use pregabalin and gabapentin together.
Yeah, I say that many of the patient might be, we usually start with pregabalin, gabapentin. We know that the mechanism is slightly different with pregabalin and gabapentin. The problem is that whether this patient will be compliant on these drugs. So most of the time we need to explain to the patient regarding the side effects profile. One thing which we are not doing that. I mean, it takes time, but I would say that while explaining to them, they will be aware what is going to happen in a few days' time. Maybe starting with a very low dosage, slowly tapering up, titrating up. That would be the message I need to give. Because what happens is that if you're not communicating with the patient, they might come in the next day or 1 week after that saying that I'm not able to take this medicine. I'm not happy with the medicine. Usually, in any case, this medicine will take 2 to 3 weeks to act. So that is a very important thing. The time to response is actually might take 2 to 3 weeks. So in such case, we need to tell the patient that you don't need to change the drugs quite often. So we won't get the desired response even with the minimal dosage. Now, when you say like you can see the dosage even in the American guideline, the UK guideline are all 300, 600. None of the patients here will tolerate such dosage. I've seen patients tolerating 10 milligram, 23 milligram, 50 milligram. Now whether it is a placebo effect, I won't say, I don't know currently, because finally the patient should be happy with the treatment. Now the message should be always start with the low dosage, slowly titrate up. There are few instances like pregabalin where you can speed it up. There is no need to wait for 2 weeks. Even with 1 week, 5 days, you can titrate up. But the other one, the gabapentinoids, the TCAs, the SNRIs, need to give time.
One more question, Dr. Sharath, that in the mononeuropathy with pain, we have this any role of this TNF and TNF antibodies usage to reduce the pain, because the pain is very excruciating. Any comments on that?
Currently, I would say that even for mononeuropathy, is actually it is painful, and it's basically the option. Like we can have a local intervention which can helpful. I would say that rather than giving any, if the patient are not compliant to drugs, and even a local intervention can help. We used to give a steroid injection for entrapment neuropathies. That's local steroid injection. Actually, they do well. Even we don't need to do a tenotomy or any tendon release. Even a local steroid injection. So in that case, I would say that would be much better than when the patient are not responding to the routine drugs. The local or the interventional therapy would be much better, because they will have a prolonged effect.
Okay.
Dr. Sharath, there is one question by Dr. Parameshwari, who had asked about the duration of therapy for ALA and whether the tablet form of ALA is effective.
Yeah, that's a good question actually. So to be frank, ALA is a hot topic still. ALA is a hot topic, and even if you take ALA drug like 100 milligram, that dosage 200 milligram, I wouldn't say that is much effective. Usually you need to have a high dosage of ALA. So usually what by standards it say that 600 milligram. So we have given patients with 600 milligram ALA. So problem is that sometimes I have burnt my fingers with ALA. With the Hirata disease, which I have quoted, this is not that uncommon. If you go with high dose ALA, there is a chance that you can, if the patient is if the patient has some genetic polymorphism of developing a Hirata disease, in Asians it is common. So then it is a what I would say is the end. Hirata disease is a very difficult to treat disease. You need to go with immunotherapies, and also ALA, I would say, is a double-edged one right now. Even if you want to continue, you have to continue on a higher dosage.
Dr. Sharath, there are two questions from my side. Can you hear me?
Yeah, yes, ma'am.
The first question is, say, escalating the dosage of either pregabalin or gabalin. I have seen many prescriptions from neurosurgeon and neurologist writing 300 milligram BD, 400 milligram BD. So do you think this much of medication is required? Because neuropathy, they're already dosed off, they're unable to walk, and with such a high dose of medicine, they will not do good. And what do you say about, I have seen many of the doctors, especially diabetologists and podiatrician, they are giving some monofilament light therapy, which is improving peripheral neuropathy, they say. Do you know anything about that?
Yeah, that's I've skipped that slide actually. TENS, laser, and these things are actually they will give some temporary relief, and on a long term, I won't suggest that these are any curative treatment. And regarding the first question, see, I mean, basically, I would say that any neurologist would definitely start with the 300 dosage. Neurosurgeons, I have seen a lot of, as ma'am's told, I've seen a lot of prescription with 300 dosage and all. The problem is that, I mean, most of the time, patient won't be compliant on this dosage. And they usually come with this problem of side effects of these drugs. And in such case, what I usually do is that I take a drug holiday. So because once you are giving a high dosage of medicine, if you want to titrate up or down, it is not possible. All the receptors will already been saturated with this drug for a quite long time. So we usually, what I do is that I take a drug holiday, stop all the medication, not abruptly, but slowly tapering down on time, and then we'll give a holiday, and then we'll restart with the lower dosage. This is what I used to do. So that is a quite common thing. I mean, we have seen cases of case sheet or prescription with 300 dosage. Neurosurgeons, we have seen a lot of cases, but neurologists, I would say nowadays they are going with a guideline or protocol based.
I have one question. So, thank you for a good presentation. And as you have mentioned, and as Madam has mentioned, the tolerance to the drugs used in the peripheral neuropathy is not that much good, and the effect is also questionable, and there is a reversibility. And many tests which we are doing to find out a neuropathy, we do only to diagnosis, and it may not have much bearing on the treatment of the patient because we don't have much effective intervention. So do you have any non-pharmacological intervention, especially in an advanced case where we may not be able to give any medication? And we have a lot of topical preparation for the management of neuropathy as being marketed. So I mean, especially the transcutaneous neuronal stimulation or any other intervention which is useful, as we notice in other cases useful. And pharmacological therapy, and I don't think that we have a lot of experience which many patients do not tolerate. And you have shown a slide in which the American other recommendation of high dose, even we do not tolerate half of the dose or quarter of the dose. So do you have any other recommendation for this? I mean non-pharmacological and other things.
TENS is one thing which we used to do in podiatry, but I wouldn't say that it's a very helpful procedure at this point. But in refractory cases, TENS do well. That is trans-electrical neurostimulation, TENS, and laser therapy. That is also being done in our podiatry clinic. So that is one thing which is a non-pharmacological intervention. And other things like even for a patient with a severe painful neuropathies, the ganglion blocks. So we have given ganglion blocks for patients with severe refractory painful neuropathies. Even those patients who are not responding to the drugs, even ganglionic blocks, the ganglion, the sympathetic ganglion block is one option. It's an interventional procedure. Secondly, then infusions of lidocaine. That is one thing which can be tried. The topical presentation, I wouldn't say the capsaicin and all these, they're not bearable. I think it's because of they can have in our setup, I don't think capsaicin patch would be a good option. But the topical presentation like lidocaine, gabapentin ointment, many of them are responsive. I mean, responding to that ointment. So that local population. So intervention, of course, there are interventional procedures like this. See, if you can have a neuropathy, painful mononeuropathy, we can do interventions like steroid injections can be given. Locally, we can treat that patient. The ganglion blockades can be tried in painful refractory neuropathies. So that is one thing. Regarding drugs, I wouldn't say that drugs are not effective. Maybe to hold the progression, yeah, definitely. But many of the patients, I would say that many of the patients are doing well with drugs. The only problem is that which drugs to be started, what combination to be given. So that takes time. It's really tailor-made, and most of them need to be on regular follow-up. So I would say that by a combination of drugs, slowly tapering it up, giving time, many, I would say many are doing well on drugs itself. But we are not actually halting the progression. It's still a symptomatic relief.
One final question, Dr. Sharath. It might seem funny, but many patients at the end resort to the native treatment, like Tirumal, Pirichil, Karchil, and all those things. Is there any evidence based on that? But because they seem to have relief of symptoms with that.
Exactly. So the problem is just like, I mean, TENS. What we do in TENS is that it's basically gating mechanism. So what the massage, the acupuncture, see acupuncture, everything is actually an alternative medicine. But even if you take the ADA or any guideline, acupuncture is one of the treatment option. So I would say that these things are on a short temporary period. They will be helpful for them, and they will resort to that. But none of them are continuing this drugs, continuing with this treatment. If you see that, most of them will come back. I mean, you have seen many patients resorting to this alternative medicine, get relief, pay a lot of money, and then come back again to the modern medicine. So these are all temporary relief. Even acupuncture, all kind of. If you see now, I would say that if you see the practitioners who are doing neuropathy treatment, most of them are alternative still. If you those who are promoting neuropathies are alternative medicine. If you Google it out on the in the net, we can see a lot of packages for from Ayurveda, other kind of alternative medicines. So many of them are still going to these kind of alternative medicine. But the problem is that many will come up with the modern medicine with a much more advanced neuropathy, because they are not looking into the other fineness of the disease.
I think we had enough questions and the discussion was very good. Prashant, we can conclude, I think.
Yes, sir. Yeah.
Harish?
Anita, madam?
Yeah.
Sir.
Actually, many patients, what I have seen, our experience, most of them they start with a higher dose. So once you start with a pregabalin 25, then slowly taper it. I think they have good response. Most of them have giddiness, syncope. Most of them with starting of the drugs of 75 milligram. Yeah, that's why I think we start slowly and taper it. Most of the people, they must be having associate depression. They'll be also on amitriptyline and other drugs. And overall, we start on a this type of drugs. This will go for a more complications. That's what.
No, that is why I think Dr. Sharath has said, don't look at the right side of this slide, because the dosage which was written in that, I think we can never give to the patients. It is impossible.
Maybe we will have an Indian guidelines. I mean, it's high time actually. We should need an Indian guideline. So we don't have maybe RSSDI can team up with the Neurology Association and can have some guidelines. Indian guidelines is required actually.
We have guideline on this thing. Actually, the latest guideline is about to come. I think it's already been released on diabetes overall management. In that, neuropathy management is there, and where they mentioned this dosage.
Maybe in next few years, maybe we'll be learning much more about the Indian guidelines, not looking at the American one because we are seeing a lot of diabetic neuropathy. When you see we go out and we go for the overseas conferences, because the number of cases which we have, that is much more, and you can't compare with the overseas counterparts. So it's high time that we look into these small things and have a proper guidelines in our country.
For conclusion, what about this vitamin B12? How effective? Because most of them have come with vitamin B12 preparations, different preparations.
That I think I would say that maybe that I would like neurobiome or kind of drugs actually. Maybe if the vitamin B12 levels are normal, there is no requirement to start on any vitamin.
And most of them will be having alpha lipoic acid combination. Because,
combination also.
Even some people have come with 750. Sometimes they come with 1,500 milligram of vitamin B12. And deloxetin with vitamin B12. Deloxetin with vitamin B12. Yeah, a lot of combinations are there. Yeah.
I would say that these are all add-on drugs right now. But when a patient with associated symptoms, like a patient on metformin, we want not be looking into the B12 status all the time. So in such case, B12 is required actually. So and even if you feel that, I mean, B12 we can be assessed. I mean, we have the blood assessment of B12 also. If it is high, if it is normal, we don't need to give a B12 preparation itself. So most of the drugs, we know that with the market, the pharmacy, all these things, most of them are add-on. We just need to have a tight watch on the drugs the patient should take. Yeah.
Some people come with muscular cramps also, along with neuropathy cramps. Yeah. So recently there are some they come with magnesium combinations. They have found some relief because they bring some normally literature showing that magnesium with the vitamin which is having magnesium has showing because
So the
for
problem
cramps,
is that problem is that I don't think the magnesium B12 combination, the per se is a good combination regarding the uptake and all these things. They should be given at different time. So there are a few things. So most of these drugs which is marketed as a complex, I think I should it should be warned that whether we need to have a combination drug in most of the time, because the absorption won't be normal in many of the times. So in that case, individual drugs would be better.
I think we should conclude, no?
Yeah. So, thank you, Dr. Sharath. I will hand over mic to Prashant to give the concluding remarks.
Thank you, Dr. Sharath, once again for that very enlightening talk. We have covered almost all aspects of diabetic neuropathy. And we had a very good discussion at the end, and we had a good number of participants also today. And I would also like to thank the chairpersons for initiating a good discussion and giving a good introduction about the topic. And once again, thanks to all the attendees who have joined in, stayed till the end of the discussion. We had more than 50 or 54 participants at one time. And we will be continuing with the series of Diabetic Crossroads every month. Next month, as we are having our quarterly meeting at Palakkad, we won't be having the Crossroads as we conventionally do. But from January onwards, we will be continuing with the next Crossroads episode. So thank you once again for joining. Thank you, Sharath, and thank you, Dr. Hari and Nandakumar. Thank you all.
Thank you all.
Good night. Good night.
Thank you. Good night.
We will be uploading the meeting in our YouTube channel, and the links will be forwarded in a couple of days.
Thank you.
Thank you. Thank you.
So, madam, we'll wind up.
Yeah.
Okay, I'm stopping.
Yes, sir.